All right. So hey everyone, my name is Yusuf. I'm one of the second year residents here at UofT. I'm also going to be introducing some of the other presenters here today. So we have Dr. Taylor Lukasic, who is a fifth year PGY5 here at UofT. We got Dr. Gia Yu, who is one of the gas fellows here at UofT, and then Dr. Diego Ricati Ortiz, my apologies, one of the glaucoma and anterior segment surgery fellows. We'd also like to thank Dr. Burt, Dr. Karani, and Dr. Schlenker for their guidance and support for this presentation. And then we'd also like to thank the speakers at Wright for granting us use of some of the information on their slides. So we felt it useful after a great weekend learning so much about glaucoma to list a few pearls that we learned from last weekend. I'm not going to read all these out. They'll be kind of dispersed throughout the presentation, but we'll be going through a high-level overview of some of the talks with some of the key take-home messages that we learned from these. So I'll be getting started. I'll be getting started by just giving a few main points from Dr. Michelle Lim's talk. Dr. Michelle Lim is a professor of ophthalmology and vice chair at the UC Davis Eye Center, and she gives a great talk on an approach to Rnfl and ganglion cell complex analysis in 2023, which has become a really big staple in the everyday glaucoma and comprehensive practice. When we look at the Rnfl printout, there can be a lot of information. There's the tomogram, which Dr. Lim encouraged us to look at to ensure that there's appropriate segmentation and acquisition in order to make a reliable analysis. There's a parameter table, the thickness maps, Rnfl, neuroretinal rim, T-SNP plots, and then the clock hours below. And this can be a lot. And Dr. Lim kind of got us to hone in on some of the key areas when looking for glaucomatous pathology. Specifically, she told us to look for some key pieces here with the average Rnfl thickness portion and the parameter table. And these areas have been shown to have very high diagnostic accuracy for evaluating for glaucoma. The same also goes for the inferior quadrant thickness, which is located below. And this has been shown from studies from 2010 to 2016. So whenever there's kind of a lot of information, it's very useful to hone in on these areas. And that's what Dr. Lim suggested to us. She also suggested to look at the Rnfl deviation map for any possible infratemporal Rnfl area that's thin. And this area has been termed the macular vulnerability zones by Hood et al. And studies by Leong et al. Have also mentioned how glaucoma commonly infects the infratemporal Rnfl. It should be noted that this loss typically occurs starting at around 2 millimeters from the center of the disc. However, the Rnfl radius of measurement is 1.73 millimeters. So what does that mean? That means that we may not necessarily see the inferior quadrant clock hour correspond to a thin Rnfl in that area until the infratemporal Rnfl has thinned beyond a point where it's reached that inferior clock hour. And this can really be best illustrated as Dr. Lim gave us a picture of a guided progression analysis on the Rnfl. You can see on the left-hand side of the screen in 2019, there is that infratemporal Rnfl, that area that's thin, but jump all the way 4 years later to 2023, then it's only reflected on the inferior quadrant clock hour. So you should have that in the back of your mind to make sure that you're not missing any early glaucoma or glaucoma progression. Essentially, look at the infratemporal Rnfl on the deviation map. And that brings us to our first pearl of Walter Wright from Dr. Lim's talk. The infratemporal Rnfl, i.e. the macular vulnerability zone, is an area that's most susceptible to glaucomatous damage, and it can be seen on Rnfl and GCC testing. Damage to this area warrants investigation with a 10-2. All right, so next up, we'll be shifting gears and reviewing some of Dr. Rahul Sharma's talk. Dr. Sharma is a neuro-ophthalmologist here at UofT, and he gives a great talk on identifying imposters in the glaucoma clinic, essentially speaking to us about an approach to identifying non-glaucomatous optic neuropathy from glaucomatous optic neuropathy. He spoke about how causes of acquired cupping are not always due to glaucoma. They can be due to toxic or nutritional causes. They can be due to ischemic causes, hereditary, inflammation, compression, infiltration, and so on. He also spoke about how maybe we're not as good as we think in differentiating non-glaucoma from glaucoma. And studies have reported 44% of patients with non-glaucomatous optic neuropathy to have initially been reported as glaucoma. And this is even with those amongst cup discs. So kind of the issue a lot of the times comes when we see a cup disc and we think glaucoma, but it may not actually be so. He brought us about specific areas in which we can look for on history, physical exam, on the eye exam, and also on the Rnfl visual field to help us identify glaucoma from non-glaucoma. And on history, he told us to specifically kind of have in the back of our mind an attention to the progression of their symptoms and whether they're acute, subacute, or rapidly progressive. This could possibly indicate non-glaucomatous origin. He also, on the other hand, told us to look for secondary causes of glaucoma, like pseudo-X or pigment dispersion. That can point the other way towards glaucoma. If there are hereditary, toxic, or nutritional elements on history, a history of trauma, neurologic symptoms, or symptoms of hypo or pituitary hypothalamic dysfunction, this could point to non-glaucomatous causes of optic neuropathy. So it is important to have those in the back of your mind. Regarding the physical exam and the ocular exam, if there's visual acuity, color, or visual field loss that's out of proportion to the cupping, an RAPD, an early color vision loss, early central visual field involvement, or pallor of the residual neuroretinal rim, you should have non-glaucomatous optic neuropathy as a cause in the back of your head. Looking specifically towards non-glaucomatous Rnfl, ganglion cell, and Humphrey visual field patterns, it's useful to be able to identify non-glaucomatous patterns to help make that distinction. In glaucoma, we know from the previous Pearl that it often affects the inferior and superior poles and also the inferotemporal Rnfl, and this can correspond to arcuate defects seen on the visual field. If we move towards chiasmal causes and non-glaucomatous optic neuropathy, this can often be reflected here with a binasal hemiatrophy on the Rnfl and GCA, and then also bitemporal hemianopia or junctional scotomas. So lesions that respect the midline on visual field should kind of put a warning red flag when you're looking at these. And then just another example Dr. Sharma was able to give on mitochondrial and nutritional deficiencies and non-glaucomatous causes. The Rnfl will commonly be affected in the papulomacular bundle, and this would be reflected most often as a cecocentral scotoma here, which you can see on the visual field. So as far as Pearl number 2, from Walter Wright, a cup disc does not automatically mean glaucoma. So we should be carefully looking for elements on history, like progression, physical exam, like early visual field loss, central visual field loss, color, RAPD on physical exam, and then also those key characteristic visual field, Rnfl, and GCC patterns that can point towards non-glaucomatous optic neuropathy. I'll finish off my portion of this recap by talking about Dr. Devesh Varma's talk on gonioscopy versus anterior segment OCT. And Dr. Varma is a glaucoma and anterior segment surgeon here at UofT as well. So gonioscopy is a tried and true form of angle assessment, but it must be done in the right form to adequately assess when we are at highest risk of angle closure. And that means minimizing light, minimizing compression on the globe during gonioscopy, and then also performing indentation with a Zeiss or assessment lens to check for appositional closure versus plateau iris, and then also assess for peripheral anterior synechia. And I was really taken at how there's an anterior segment OCT diagram here on the bottom. It shows how much the anterior chamber really opens up with light. And you may actually be masking a true closed angle if you are putting too much light or there's too much background light in the room. He also gave us a quick overview on how to read anterior segment OCT, in which the goal for us is really to rule out iridotrabecular contact. And to help us with this, there are a few things that we can do to landmark. And the real goal is to identify the trabecular meshwork, as we mentioned above, and see if there's touch with the iris. So first, looking at the scleral spur, you can see that pointing towards the blue arrow on the slide. It appears as a wedge and a changing curvature on the inner wall of the cornea, and also represents the thickest portion of the sclera and where that indentation changes. You also should be looking for Schwabe's line, by identifying the outer limit of the endothelium showing up as the U-shaped interface with that yellow corresponding wedge, and then looking for a changing color from the dark corneal stroma to the light sclera. And If you landmark these two structures, you know that the trabecular meshwork should be halfway approximately between these two structures. He was also able to speak about how anterior segment OCT may be better at detecting angle closure early, and he was able to discuss some of the findings by a study from Bhaskaran et al. And this group aimed to determine the rate of gonioscopic angle closure after 4 years in subjects with an open angle on gonioscopy, but varying amounts of angle closure on anterior segment OCT. The study included patients who are completely open on gonioscopy, but had at least one quadrant closed on anterior segment OCT. And what they found was that 17.3% of those who are completely open 4 years later, they had at least two quadrants closed on gonioscopy. And amongst also 4 years later, for those who had at least 3+ quadrants closed on gonioscopy, this was 4 years later, and it was a bit of a smaller proportion. So the conclusion of this study was that anterior segment OCT predicts gonioscopic angle closure after 4 years. And this may be because of some of the prevention of user elements when performing anterior segment OCT. As far as my final pearl, which comes from Dr. Varma's talk, that is that the risk of angle closure needs to be assessed in a situation with the highest risk of occurrence, which means minimal light, no indentation. Anterior segment OCT is less operator dependent and can be performed with minimal light. So that's possibly some of the reasons that it allows for earlier angle closure detection. However, gonioscopy should still be performed with indentation to distinguish between lens rise and plateau and to assess for peripheral anterior synechia. So with that, I'll be passing it along to our next speaker. I'll unshare my screen.
Thank you, Yusuf. That was great. So we'll keep going and save any questions for the end, if that's okay. Thank you, Taylor.
All right, guys. Hi, my name's Taylor. I'm one of the PGY5s, and I'll present to you my pearls from the talk. So first, I'll talk to you about Tin Ong's glaucoma genetics in clinical practice. Dr. Ong is from the National University of Singapore. Sorry. Oh, there we go. Okay. So he talked to us about a polygenic risk score for primary open-angle glaucoma. And the polygenic risk score represents a genomic profile of an individual based on all of the known risk loci for that disease. So for POAG, there's 312 loci, and for primary angle closure glaucoma, there's 8 loci that have been identified. So they take the sum of these loci that an individual carries and compare them to the population to determine their percentile risk within the population distribution. So there were strong associations with between the POAG and the PRS. If we look at the age of diagnosis, individuals in the top 10% of the PRS were diagnosed with glaucoma 7 years earlier than people in the bottom 10%. There's also a strong association with Rnfl change. For each decile change in the PRS, there was an associated accelerated progression of 5 microns a year. These patients were with a high PRS were also more likely to have incisional glaucoma surgery. So there were also some predictive value of the PRS. The PRS, the top decile of the PRS had a 15-fold increased risk in advanced glaucoma. There was also improvements in predicting progression in glaucoma or progression to primary angle open glaucoma above traditional risk factors such as sex, age, and family history. When you added the PRS, there was a significant change in area under the curve from 0.73 to 0.8. Now, this was not significant for primary angle closure glaucoma. The anterior chamber depth, as measured by ASOCT, actually had a better predictive value for primary angle closure glaucoma when compared to the PRS, with an area under the curve of greater than 0.85 compared to 0.8 of the PRS. So it did not improve the area under the curve above the discriminatory value of the ACD. So how will we use this in the future? Well, we'll be able to have more precise medicine. We'll be able to identify people with higher PRS scores and follow them more closely, or intervene more quickly to prevent progression of their disease in primary angular glaucoma. Today, there's not a commercially available test, but this will be coming soon in the next few years, and we'll be able to offer our patients more tailored management that works best for them. So Pearl 1, the polygenic risk score for POAG may have significant implications on identifying, following, and intervention decisions in the near future. Next, I'll talk about physiologic versus pathologic progression in patients with glaucoma. This talk was given by Dr. Matthew at the University of Toronto. So the OCT and the Rnfl trend analysis, normal eyes lose around 0.5 microns of Rnfl thickness every year under normal circumstances. There's also a little bit more loss superiorly and inferiorly, just greater than 1 micron a year. If we look at this OCT here, we can see that the average loss is just under 2 microns a year, where if the superior Rnfl being fairly flat at around 0.2 microns loss a year, and the inferior Rnfl is greater than 7 losses greater than 7 microns a year. Therefore, we should always look for focal thinning in the Rnfl, like the inferior Rnfl in this example. But we can look at the average Rnfl and see if there's a greater than 1 micron loss to probe further to look for any of these focal defects. And we should also keep in mind that healthy eyes have 0.5 micron loss a year. Non-progressing glaucomatous eyes can have up to a 1 micron loss a year, and progressing glaucomatous eyes can have over 1 micron loss a year to around 2 microns a year. As we reach the Rnfl floor in advanced glaucoma, the rate of loss slows to around 1 micron a year. So the same is true for ganglion cell analysis, where an average eye has an age-related change of around 0.3 microns a year, with a glaucomatous changes having a more accelerated rate of loss at around 1 micron a year. So if we look at this example of a ganglion cell analysis, we can see that the rate is just over 1 micron a year, but you still need to look for focal changes. As you can see in the baseline, in the heat map area, there is a horizontal Raphe sign, which is progressing over time. So looking at the average is not the be all and end all. You still have to look at trends in the heat maps as well. So visual field changes over time. There is a normal average change, age-related change of negative 0.4 decibels a year. Slow progression in glaucoma is around negative 0.5 to 1 decibel a year. Moderate progression is around negative 1 to negative 2 decibels a year, and fast progression can be considered more than 2 decibels a year. We know from the early management glaucoma trial that in eyes that reach progression, the mean change in baseline was around 1.93 decibels a year, which is just around the 0.4 decibel threshold. Therefore, non-progressing eyes should have better mean deviation trends than progressing eyes. And if we look at this example of our visual field here, the VFI trend actually is quite flat when you look at the graphical representation. But when you look at the percentage or the decibel loss a year, it's around negative 0.6. And you can also look at the pattern standard deviation here, and you see that there's a progressing superior nasal step. So we need to still look at all of the information given to us and put it into context. So Pearl 2, Age-related visual field, retinal nerve fiber layer, and ganglion cell loss must be considered when assessing for progression in glaucoma. Next, I'll talk to you about the safety of oral carbonic anhydrase inhibitors. That talk was given by Dr. Schlenker here at the University of Toronto. So Dr. Schlenker and Dr. Popovic, another one of our University of Toronto residents, did a study about the serious adverse events of oral and topical carbonic anhydrase inhibitors. That was published in JAMA Ophthalmology of last year, January of last year. Serious adverse events like Stevens-Johnson syndrome or toxic epidermal necrolysis and aplastic anemia. They looked at data banks of prescribing info that is kept by the Ontario government and ICD codes. They looked at just under 130,000 consecutive patients in Ontario over the past 25 years. They found that there was very, very, very few serious adverse events. And as you can see here on the graph, the cumulative risk per 100,000 people is so low that we need to change the y-axis to show you it. So when we look at the oral carbonic anhydrase inhibitors, the absolute risk was 2.9 per 100 or per 1,000 patients after 120 days follow-up. For topical CAIs, the absolute risk was 2.08 per 1,000 patients after 120 days follow-up. The hazard ratio was 1.4, and this was statistically significant. When you compare oral and topical carbonic anhydrase inhibitors, there was a 40% relative increased risk of a serious adverse event, but this is expected as oral medications act more systemically. So what about patients with a self-allergy? Well, someone has looked at this. There's really an absence of cross-reactivity between sulfonamide antibiotics and sulfonamide non-antibiotics. So in a sulfa allergy, you're more likely to have a reaction to penicillin than you are to sulfonamide non-antibiotic like Diamox or methazolamide. So in summary, acetazolamide and methazolamide are unlikely to cause severe adverse events, even in patients with a sulfa antibiotic allergy. You need to know if your patients have kidney impairment or liver impairment, because in kidney impairment, you should consider using methazolamide as acetazolamide is excreted through the kidney. And in liver impairment, you should consider acetazolamide as methazolamide is excreted or is broken down in the liver. So you should also not minimize the side effects of these medications, GI upset, lethargy, and paresthesias. But bringing us to my last pearl here, do not withhold oral carbonic anhydrase inhibitors as a bridge option for patients who are losing vision due to debunked myths or irrational fears. So that was my last pearl. We'll hand it off to Gia. Just stop sharing my screen here.
Great. Good morning, everyone. I'm Gia. I'm one of the glaucoma fellow. So I'll be talking after UofT and Taylor, and here's my top pros from Wright this year. First, we have a great lecture again by Dr. Lim, who's from UC Davis. So this lecture is about managing your thoughts on managing glaucoma medication. And I found it very interesting. This is a question I often get from my patient, actually. When you prescribe them a prostaglandin QHS, they come back the next visit, and now they're wondering, well, do I really have to take it in the evening? Can I take it some other time during the day? Can I take it in the morning? Because I tend to remember better when I take in the morning. And I didn't really know what to tell the patients until Dr. Lim presented this nice study here about the effect of intraocular pressure and side effect of latanoprost applied daily, evening, and morning. So we have a very nice graph here on the y-axis showing the intraocular pressure of the patient. On the x-axis, the duration of the treatment. So everybody got 26 weeks of drops. Just for sort of a control, let's look at timolol here. This is the white square. Initially, the pressure before starting the drops was around 25 or so. pressure lowers down to 17 and 18, and it stays about the same throughout the whole 26-week. If we look at the latanoprost group in the first one, so the patients in the white circle here got morning doses of latanoprost in the first 12 weeks, and then afterwards they were switched to evening dose of latanoprost in the next 12 weeks. And we can notice already that there's a decrease in the pressure when they start taking their drops in the evening. The same is true if we flip it around. So here the patients in the black circle, they got their latanoprost in the evening in the first 12 weeks. And then the same patient got their drops now in the morning, and then the pressure went back up. So in both circumstances, we can say that latanoprost in the evening shows a little bit of a pressure reduction compared to latanoprost in the morning. So to answer the patient's question, can I take my drops in the morning? Well, actually the answer is no, because latanoprost work better when we take them in the evening. This is also a slide from Dr. Lim's lecture, and I found this to be interesting too. So we have here, which is better, these two combination drops, is dorzolamide timolol, which is COSOP, better, or is brimonidine timolol, which is Combigan, better? This is an interesting thought, because a lot of our patients have pressure that are high, but only in one eye. And so in these circumstances, you don't really want to start them on a prostaglandin drop, because you don't want them to have long eyelashes or color iris change in only one eye. So you would ideally start them on some sort of aqueous suppressant. And if their pressure is in the high 20s, you want to start a combination drop. And often the debate is, do we start COSOP or do we start Combigan? So there's a nice study that looked at exactly at this issue here. So we have 24 hours of efficacy with dorzolamide timolol compared to brimonidine timolol in primary open-angle glaucoma. We see on the graph here, so the mean on the y-axis again, the mean intraocular pressure. And on the x-axis, we have the time in 24 hours. So the gray one is the brimonidine timolol, which, as we can see here, is a little bit higher than the black line, which is dorzolamide timolol, by about 0.7. So we can say, based on this one study, COSOP here works actually a little bit better than Combigan. So pearl number 2, dorzolamide timolol in combination, it leads to better 24 hours IOP control than brimonidine timolol. Next, we had a great lecture by Dr. Lam about glaucoma drops in pregnancy. So we know in pregnancy, there's a few categories of medications, A being sort of the safest, and then D being with the risk of fetus, X being definitely we cannot give to the patient because they're teratogenic. And so in people, in our patients who are young and who are at age for reproduction, those who are trying to get pregnant, or those who are already pregnant, sort of the first line treatment in these patients is actually SLT. But if SLT doesn't really work and you have to start them on some sort of drop, then all of our glaucoma drops sort of fall into category B and C. We don't really have any drugs in category A, just because, you know, the nature of the pregnancy, it's hard to make any sort of real study looking at pregnant women and their reaction to drops. The only drop that is possibly safe in pregnancy is brimonidine, and all the rest falls in category C. In the first trimester, the Academy of Ophthalmology suggests to use alpha agonists as first line, and actually this encourages us to use beta blockers, carbonic anhydrase inhibitors, and prostaglandins because of the risk of potential teratogenic risk and also premature abortion as well. In the second trimester, alpha agonist is still the first line, but now we can start considering beta blockers, carbonic anhydrase, and also prostaglandin as well. For beta blockers, we just have to monitor the fetal heart rates. For carbonic anhydrase inhibitor, we have to monitor for fetal growth retardation. And for prostaglandin analogs, we have to sort of tell our patient that prostaglandin can actually increase the risk of premature labor. So they have to be aware of what are the symptoms of premature labor. In the third trimester, we have to stop the alpha agonist, especially closer to the due date, because of the CNS depression risk in newborns. We all know we cannot give brimonidine in people, kids who are less than 3 years old because of the life-threatening side effects. And we can no longer give prostaglandin analogs. because the risk of premature labor is much higher in the third trimester. So that leaves us with beta blockers and carbonic anhydrase inhibitors for the third trimester. And again, monitor heart rate in beta blockers and monitor acidosis and growth retardation in carbonic anhydrase inhibitor. So while the patient's pregnant, antenatal alpha agonist. And then when the patient is breastfeeding while the baby is born, we can use now beta blockers or carbonic anhydrase. So these two are okayed by the American Academy of Pediatrics. They say that this is safe in nursing, and definitely do not give any alpha agonists because this can go through the breast milk and then go directly to the infant. So pearl number 3 here, in pregnancy, we can give alpha agonist, and closer to the due date, we can switch from the alpha agonist to beta blockers or carbonic anhydrase inhibitor. Next, we have a great lecture by Dr. Karani from University of Toronto here about corneal hysteresis. So corneal hysteresis is a really hot topic these days. It is now in the AAO manuals, it's in OFT questions, it is everywhere that you can read about glaucoma these days. And what exactly is corneal hysteresis and how do we measure it? So even though it has cornea in its name, corneal hysteresis is actually more relevant for glaucoma in the diagnosis of glaucoma and to monitor progression. So what happens is that we have a machine that sends a little jet of air to the cornea, it indents the cornea, and then afterwards the cornea rebounds and reforms its shape. So the machine measures the pressure when the cornea is indented and also measures the pressure when the cornea is on rebound. The pressure initially at indentation is always a little bit higher than the pressure that we can measure at rebound. And so the value is always positive, and this value that's a difference between the two is called the hysteresis. And corneal hysteresis CH is sort of particularly helpful in the diagnosis of glaucoma. So here we have a meta-analysis with a few papers published already, and you can see all of the paper published that in normal patients, their corneal hysteresis tend to fall between 9 and 11. But when we look at the different groups of glaucoma disease, all of them have very low corneal hysteresis. The highest being 10, which is in ocular hypertension, which is sort of the closest we can get to normal people. The one thing to note here, normal tension glaucoma also have low corneal hysteresis, so this is a great indicator to help us diagnose the disease. So if you see a patient who have a CH less than 9, you're more concerned that they have glaucoma. And if you see a patient who have a CH bigger than 11, then you're much less concerned about glaucoma. So pearl number 4, corneal hysteresis, is IOP at indentation minus the IOP at rebound. For the diagnosis of glaucoma, the smaller the difference between the two pressure, the less flexible is the cornea, and therefore the higher the risk of having glaucoma. And that's it for me. I'll pass on to Diego.
Thank you, Gia. Let me just share my screen. So for the last couple of points we want to make for this grand rounds, I'd like to go back to Dr. Dinong's talk about the management of PACS. Summarizing, this talk mentioned a few of the recent studies made on the management of this particular disease, and he included in his talk the recent SAP trial with 2As and the analysis studies. And I'd like to just mention that what it all boils down to is basically these two slides. So who should you consider LPI is a good idea in? So every patient with primary angle closure glaucoma, or a history of acute primary angle closure, definitely good candidates for an LPI. However, when we're talking specifically about primary angle closure suspects, that's when it gets a bit fuzzier, since what's been shown is that the risk for progression from primary angle closure suspect to actual optic nerve damage or glaucoma is very low. So when do you want to do an actual laser for this group of patients? Well, if the patient is symptomatic, if the patient, for instance, is diabetic and has to have regular dilated eye exams, it's also a good idea. If the patient has a poor access to healthcare or lives in a remote location where access to healthcare would be delayed, it's also a good idea to prevent an acute attack. If the patient has a family history of an acute attack, or consider the patient's wishes, and if the patient feels that they feel safer doing the laser after explaining risks and benefits, it's also a good idea to do an LPI. So for my next, this would be the first pearl. LPI is an appropriate treatment option for PACS in high-risk patients. Examples are frequent dilation, family history, and acute angle closure glaucoma, excuse the typo here, and poor access to healthcare. And of course, primary angle closure glaucoma, and acute primary angle closure. For my next pearl here, I'd like to go and mention Dr. Asaura Blanco, who gave a couple of talks, but specifically he gave us a really nice summary of the Eagle study, in which he was one of the main authors. And this study is very important for the management of primary angle closure glaucoma or primary angle closure. In this study, they gathered a group of 470 participants with primary angle closure with a pressure of 30 or with properly diagnosed primary angle closure glaucoma, and they were randomized into two groups. So one of them was the FACO group, and the other one was the LPI group. And they evaluated a few parameters. First of all, they evaluated quality of life, which is down here, the EQ5D score. And they discovered that when doing lens extraction, at 36 months, the quality of life was at least the same for the patients. And when we compared to laser PI, the quality of life did decrease by a bit. So more quality of life. When we take a look at the raw numbers for IOP, with the lens extraction, the baseline pressure was around 29.5, and at 36 months, the pressure went down to 16.6. Also, this includes patients who require glaucoma surgery during the 3-year follow-up for both groups. So consider that. And for the laser PI group, the pressure went down as well, but not as much as the lens extraction group. So better results for IOP control as well. Other parameters they assessed was the number of medications at the 36 months follow-up. And again, the lens extraction group performed better here with the total number of medications as a mean of 0.4 compared to laser PI, who had to use 1.3. And if we compare the number of patients who have no medications, you can see a big difference of about 60% on the lens extraction group compared to only about 21% on the laser PI group. So significantly reduced the need for medications, and the need for additional surgery on the lens extraction group was also less. So out of the 208 patients, only one needed additional surgery compared to 24 patients who needed surgery, which is about 10% of the whole laser PI group. So better outcomes in that aspect as well. So problem number 2 would be lens-based surgery is a good treatment option for primary angle closure with pressures more than 30, which is what the study included, and primary angle closure glaucoma. And even after an acute angle closure glaucoma, even though the lens would be clear, which is obviously, if you had a cataract, you would take it out and that would be the end of it. But if the lens is clear, do consider this as a treatment option. And finally, I would just like to mention Dr. Shibani and his talk on premium or presbyopic IOLs used in glaucoma. So the main thing here is that traditional multifocal intraocular lenses reduce contrast sensitivity. So as you can see, the slideshow in the middle has reduced sensitivity, and it really makes it hard to see. It's not something we really assess on our day-to-day with our patients, but it's something patients really struggle with, especially, for instance, when driving at night. It's something that patients really struggle with. So these lenses work by diffracting the light, so the total amount of light that is focused on the retina is less at a given distance, and that really can reduce the contrast sensitivity even up to 20%. So that's why we don't really recommend using this type of lenses for our glaucoma patients. On the left, you'll see some general guidelines from Dr. Shibani as to how he likes to approach which lens to pick on his patients. So he really likes to manage the astigmatism and sets a low bar for toric IOL use to improve the patient's vision as much as possible. In the early stages, so ocular hypertension, preperimetric glaucoma, and the low risk of progression, he may consider to use any IOL. So if the risk is very low, it's okay to consider multifocals, traditional multifocals. If the patient has an open angle with minimal or mild ganglion cell loss, then Dr. Shibani considers using monofocal, EDOF, and even might consider multifocal only if the patient is fully aware of the risk and is really wishes to proceed. And if the patient has even moderate or advanced glaucoma, then it's a definite no, and he would only go for a multifocal lens. So in summary, pearl number 3 would be reduce contrast, make diffractive multifocal IOL viable only in low risk, preperimetric, or ocular hypertension. And that would be it. If you want to take a look at all the pearls we just mentioned, here's our final slide. And thank you very much.
Thank you, guys. That was a great summary of a whirlwind talk, but we got through the whole weekend, so thank you for that. Couple questions for you guys. With respect to corneal hysteresis, is that a one-time measurement like CCT, or is there value in repeated measurements with hysteresis?
There's actually, so it's a good sort of measure to diagnose diagnose glaucoma, but it's actually also helpful to sort of monitor over time. Patients with low corneal hysteresis we know that they progress more in terms of glaucoma visual field progression. So it's also interesting to repeat it. But it's not often repeated, at least for the initial diagnosis. If you have it, that would be great to get it.
Got it. So just to clarify for myself, Gia, like if the patient is progressing, are you repeating the hysteresis and expecting a different number, or what's the value in the repeat measurement?
It's I guess it's sort of hard to say because we don't have so much research on corneal hysteresis yet.
Okay.
You sort of definitely say, well, if the patient's progressing, then the corneal hysteresis becomes worse or better. But in general sense that if the patient's corneal hysteresis is always low and it gets lower, then you're more concerned that they're more likely to progress compared to somebody whose corneal hysteresis is better.
Maybe I can jump in here as well. So some of the summary research studies have shown that a patient, despite having low pressure, so let's say you had a patient with normal tension glaucoma with a pressure of 9, 10, or 11, and they continue to progress, and if their hysteresis measurements are still on the lower side, that may actually be an indication to proceed with secondary filtering surgery to reduce the pressure even lower. And it might be indicated because the patient's cornea or eye is less likely to be affected by very, very low pressures, and in fact needs those low pressures to prevent further progression. So right now, studies have focused looking at it both as a risk factor for diagnosis of glaucoma as well as for progression of glaucoma, specifically in normal tension glaucoma patients.
I also think that from a cornea perspective, if you're going through any kind of surgery, it merits repeating the hysteresis.
Yeah, no, thank you for that, guys. Another question is, do you think that the prostaglandin timing reflects the efficacy of the drop, or perhaps diurnal variance in IOP and just timing that?
So this study is trying to say that it's just it's not the diurnal variance that is in play here. It's really the fact that for some reason taking it in the evening is actually a little bit more effective than taking it in the morning.
Okay, thank you. And then I guess one other question here is, how has the studies about PACs impacted our clinical management with respect to LPIs?
Maybe we can ask either Taylor or Diego to jump in on that one there.
Yes. So as you all know, I mean, LPI is very safe procedure to perform, and you can, I mean, most patients still agree to going ahead with the procedure, especially considering the alternative risk of an acute attack and the unpleasant experience that would be. So we still do a lot of LPI, at least in my experience. I don't know if any other doctor or any other office after this new evidence has surfaced has changed their practice patterns. But I think we still have a lot of LPI patients, but we may be a bit more relaxed, knowing that if one of these patients does not wish to go ahead with the procedure, the risk in reality is very low, considering only primary angle closure suspects. Of course, if there's high pressure or optic nerve damage, then we would have to be a bit more pressing on the treatment option.
Yeah, I think a lot of people took the EAGLE study to mean that any patient presenting with a potentially occludable angle should have lens extraction, and that's not what it said. They looked at people who had a clear pressure rise of 30 or who had signs of glaucoma neuropathy. That being said, as the question suggested, if someone came in acute angle closure and I wanted to go lens-based for treatment, you'd still manage medically to get the pressure down before going to the operating room. And if you didn't get to the operating room for any reasonable length of time, for whatever reason, then an iridotomy would still be a perfectly reasonable thing to do.
Thank you. So that also addressed Dr. Bakshi's question. There's a question as well from the chat. Should family history of glaucoma influence IOL selection for a patient who, so presumably the patient does not have glaucoma, but there's a family history of it?
I think if there's a family history only, but the risk in that patient is low, if we have good healthy nerves, nice pressures, then I would consider any lens the patient would choose. But maybe the new genetic testing would help us make better choices in the future, now that they'll be available soon enough.
Amadip, if I may, a comment about, again, from a cornea perspective, we saw in the chart that there was about a point or two difference between combination drops, co-sopt and true-sopt. If, however, your patient has corneal decompensation, Fuchs, more advanced Fuchs dystrophy, we know that the carbon anhydrase inhibitor will interfere with the sodium ATPase pump in the endothelial cells and can precipitate earlier corneal decompensation. So in a patient with moderate to advanced endothelial dystrophy, I'd probably go to a combination with a beta blocker and a alpha agonist rather than something like COSOPT.
Great comment. Always good to have a corneal perspective to keep us in line here. One more question about the latanoprost timing. Asking why give it at night if the highest IOP is in the morning? Maybe Gia, that's for you.
Right, yeah, so that's a great question. Dr. Lim actually showed on a few of her other slides that prostaglandin is actually a great drop to lower the IOP at night. The idea is sort of, I guess you can imagine, to give it at night, and then the effect of the prostaglandin starts working really well throughout the night, and that lowers the IOP, which sort of peaks in the early mornings. I did not put the slides in this presentation, but she did show that prostaglandin is a great option just for that blunting of the pressure throughout the night.
Got it. Thank you. Question from myself. What's happening with GCC GPA? I would love to hear how the faculty are using that.
Sure, I can chime in. I think I think it's great. I think it's better sometimes for patients who have advanced disease because there's a little bit less of a floor effect. It still just comes down to making sure that the segmentation is appropriate, both on your baselines and then on your subsequent. So looking at your anatomy first. Now, if you have glaucoma workplace, it's going to be built in. You'll see it automatically. If you don't, you're going to have to make sure that your machine is configured so that when you get your GPA progression analysis, GCC is included on it.
Thank you. So there's no more questions in the chat. I'll give it to the faculty to for any parting thoughts before we close the round for today.
Sure. I thought I'd maybe chime in just for a sec on the acute angle closure, particularly for those in our program. There are no good evidence-based guidelines of how to treat acute angle closure glaucoma, so we just need to extrapolate from our studies. Though I can share that we've had many anecdotes where an LPI was a terrible idea in acute angle closure glaucoma. We've had neovascular glaucomas treated with LPIs just because the cornea is hazy and it was presumed to be acute angle closure. And we've ended up with hyphemas and further inflammation in an already difficult situation. We've also had LPIs performed in patients who have close to 360 degrees of peripheral anterior synechia. And the eye pressure has gone the wrong way. It's actually gotten worse after doing the LPI. And when I reflect on the cases like this and the pain and inflammation that is caused by an LPI, knowing that we have a much more definitive treatment, I think it's very unlikely that I would do an LPI in any acute angle closure glaucoma situation because we have other modalities, i.e. Diamox and AC paracentesis that can help us. And the whole goal is really to take out the lens once we have acute angle closure glaucoma. And this is going to be ultimately the treatment. I find when people have had an LPI and then we do lens-based surgery soon after, there's inflammation. The iris can be flaccid in that area, particularly when we do it temporally. And we already have small eyes where we can have all small eye complications with our cataract surgery, such as iris prolapse. And I don't think that LPI is helping. So I would try to just bring the eye pressure down, break the acute angle closure attack, and try to get ready for lens-based surgery in those patients.
I'm going to give a slightly different opinion, Matt, because my preference is to treat medically, get the pressure down, re-examine the patient, and then decide if an LPI is appropriate or not. But I don't plan to take everyone to the operating room the next day or even the next week. I'll do a PI.
Yeah, I usually wait a month is what I try to do. And sometimes they do end up staying on Diamox for a month. But if it were me, I would rather stay on Diamox for a month than get LPI and then lens-based surgery. But I think you're seeing that there's no one really knows the exact way, because we don't have a proper trial, and I don't think we ever will for acute angle closure glaucoma.
Maybe with that, I can jump in here, and I just wanted to, as Amandeep referenced, honestly thank our whole planning committee, as well as the residents and the fellows, including Dr. Slomovic, Dr. Schlenker, and Dr. Burt, just for everyone coming together for what I think turned out to be a really awesome Walter Wright. We had some great industry partnerships and some sponsorships, as well as some great artists presenting that really, I think, concluded in the highlight, which was a patient presentation for one of the members of the Glaucoma Research Society of Canada. So with that, thank you everyone for coming to today's grand rounds, kind of summarizing some of the biggest pearls from Walter Wright. And again, thank you to the whole planning committee and the team, and certainly to Sandra for really kind of coordinating and getting everything pulled together.
I would echo that everything our fans said. It was a privilege to be involved in this meeting.
Well, congratulations to you all, Dr. Burt, Dr. Karani, Dr. Schlenker, Dr. Slomovic, on a wonderful meeting and a great recap today. Thank you for our presenters, Diego, Gia, Yusuf, and Taylor. That'll conclude today's rounds. Please do complete the evaluation. It is required for CME, and we'll see you guys next week.
Thanks, everyone.
Bye.